اخويا الاستاذ دكتور محمد عرفة. محمد قدم يعني الخلاصة السريعة جدا في موضوع طويل ومعقد اللي هنبتدي نفتح فيه بعد شوية دلوقتي، والعرض كان رائع جدا up to the time. يا ريت كلنا نلتزم بالوقت كده ان شاء الله، لان في محاضرات مثمرة عايزين نكملها كلها. ندعو الاستاذة الدكتورة هبة الخشاب ان تخش مور بريسايز على الفانكشنال موفمنت ديس اوردر ان تشيلدرن. اتفضلي يا استاذ.
الميكروفون. السلام عليكم ورحمة الله وبركاته. بسم الله الرحمن الرحيم. It's always an honor to be in front of my professors and my colleagues يعني to whom I own everything I learned. Professor دكتور حامد شتلر ربنا يديله الصحة، دكتورة هدى، دكتور حامد الخياط، دكتورة هدى طموم، دكتورة أمنية رشيدي، كلهم I own them everything I learned بصراحة يعني. ف thank you so much and I will go directly to my project. طيب, maybe I will turn direction a little bit from the heavy meal we just heard with Dr. Mohammed Arafa, which was a very good presentation. So I will change direction now to another subject with functional movement disorders, type of disorders. It's a neurological disorder, but maybe not requiring treatment. So why I choose this subject? This is because we noticed recently during the COVID-19, all of us in our clinics increase in the incidence of such entity. We notice a lot of tics, right, Dr. Muhammad? You saw a lot of tics recently after COVID, right? So we saw a lot of this functional movement disorders, and we saw it in our clinic, and it had been documented as well in the literature. So there is increased incidence of functional movement disorders in children during COVID-19. There is increase in young female during the COVID-19, increased tics as well, and COVID-19 related increase in childhood tics and tic-like attacks. And even in the magazines, Mental Health, they discuss the TikTok causing tics in teen girls. It was a recent article. Excessive, unnecessary, and costly investigation of FMDs will result in misdiagnosing organic illness as psychogenic, misdiagnosing FMDs as organic, failure to recognize the kernel of organic illness embedded in the symptoms of an FMD. So in order to offer the best chance for remission and use our scarce resources wisely, we need to know what is functional movement disorder. My objectives is to how to diagnose. We will try to find today how we can diagnose by using the phenomenology and the historical rules, pathophysiology, how to treat, and to show some cases. I depend surely on UpToDate and on these books starting from 2005 till the last one in 2021 with the DSM-5 published in 2011. The functional movement disorder is part of a bigger entity called functional neurological disorder, the FNDs. So it comes under the umbrella of the FNDs. It is a clinical motor or sensory symptoms incompatible with recognized neurological or medical condition, causing significant distress. So we can see here one important subject, which is the non-epileptic seizure. It's very interesting and very important. Maybe we can discuss in another topic, in another presentation. To spice it up, or at the early morning, I want to see if you know this term. Functional neurological disorder was originally termed hysteria, and it was first described by who? What do you think? Prof. Hamdi. It's very old, the hysteria. So it came from who? Hippocrates? Or Freud? Jean Charcot? Or Dr. Ra? What do you think? So it was by Hippocrates. It is very old, actually. It was called hysteria since late 19th. And then it changed into dissociative disorder from the mid-19th to mid-20s, which is understood, yeah, because this was the era of the psychogenetic era, psychogenetic treatment, everything was psychology at that time. Then it was term conversion by Freud in late 19th to mid 20s. And the term conversion is continuing by the psychologists, psychiatrists, but not anymore by neurologists. Then Prof. Fahn on 1988 called it psychogenic. Actually, this term was not acceptable by the parents and the families and the patients themselves. And finally, they reached to name it functional on 2014. I don't know why functional, since it is dysfunctional, but maybe it sounds better for the patients. So the hysteria, it came from the word hyster, which was related to females as usual, and it was claimed that a wandering womb was responsible for many medical and psychological conditions. And this woman involved was called devil patches and had been executed outside countries. And this is the one I'm using as in my presentation is an oil painting present in one of the university, in one of the hospitals in Paris. And it shows, this is Prof. Charcot, Jean Charcot, and he is giving a clinical teaching, bedside teaching to his students. This female affected by a functional neurological disorder called Marilla Blanche, and this one is Babinski. This one holding her is Prof. Babinski, and we can see here Prof. Latourette and many professors, French scientists. So let's jump now into the disease, which is functional movement disorder, and it is a clinical syndrome defined by occurrence of abnormal involuntary movement, which are incongruent with a known neurological cause, significantly improving on neurological exam with destruction or non-physiological maneuvers, and we'll be seeing that soon. So I depend on this mainly mini review, which was published recently on 2020. It started with 12,000 articles, but it ended by 34 after removal of the duplicate and so and so. It is a very important review, and according to this review, we can see that the epidemiology is not, it's not precise because the incidence and prevalence are unknown as population-based studies are unavailable. We can estimate that it is among children vary between 2 to 4%, which is similar to that of adults. Higher prevalence among girls, understood, compared to adult ratio. Cause may be attributed to complex interaction, social, cultural, biological factors. FMDs tend to have abrupt onset and account for 4 to 23% of acute movement disorders, according to adult studies. Now, how to diagnose it? So will depend on phenomenology. The presentation of this disorder. There is 3 most common observed phenomenology, including tremors, dystonia, and myoclonus. Gait abnormality, psychogenic tics, Reiter cramp, and abdominal dyskinesia, speech disorder, bizarre limb movement, acetosis, drop head. Actually, in the literature, I cannot find VGs for children, so I will depend on adult or adolescent VGs, and then I will show you ours. This to explain clearly the phenomenon. The tremors. We'll start with the functional tremors since they are the most common. You can see how the tremors here are very fast. They are different from those described by Dr. Muhammad in his presentation. So they are very fast. And you can see here the tremors in the right hand, but when he's pouring the water by the other hand, it stops on the right hand, which is entrainment. We call it entrainment. So there is a changing in the frequency, changing in frequency if you ask the patient to use the contralateral side, as well as by destruction. So it is easily destructible. This patient will be asked now to put a mouthpiece, and you can see how the tremors vanish. And he will repeat again the movement after he put the mouthpiece. And it is completely different. There is a change in the frequency. So the destructibility, change in frequency, and entrainment are the main clues to diagnose the functional tremors. This one of my patients, and she's having a functional tremors, and it is distracted by writing. Dystonia, which is the second phenomenon. And you know that dystonia, you had just been seeing in a video now, that dystonia is usually stereotypic. So here in this patient, it could start stereotypic, but then it will change. So he's looking to one direction, the limb is changing. It was in the right and then now in the left. So the dystonia is changing. It is variable. It is destructible as well. There's some examples of my patient. This one has many functional movement disorder. I will show you some videos for him again. And he's having dystonia of the upper limb, as you can see. This one is spastic cerebral CP with regular dystonia. It is not a functional, so there is a difference and we can see it. This boy is having dropped head, functional. And this is a drawing for a functional dystonia of the arm. As regards the gait disorder, this one is interesting. You can see how is the gait wide-based. The gait is clearly wide-based and it is very erotic. And there is an important sign, which is knee buckling. There is a knee buckling in both patients. And you will see now that there is two presentation which we cannot find in a normal neurological. When he is distracted by running, the abnormal gait disappear. So it disappears by distractibility, and you can see that he can go backward. Backward movement for a patient with neurological disorder is nearly impossible. So he is doing a very difficult gait examination. Well, this one by distractibility, it disappears. We have a functional myoclonus or bizarre limb movement. And it is recognized by being a full body jerks. So we can see full body jerks may be associated with some vocalization, which is not regular for myoclonus. This patient is having changing jerks from one limb to another one. So he's having jerks here, and then he changed to the other one. And it changes as well in frequency, affecting many limbs. All are clues to diagnose the functional movement disorder. And this is the text which had been nicely presented as well in the first lecture. This girl is having a text with a vocalization which disappears completely during sleep. This text as well, or we can see the dropped head. And this is the first boy I showed to you with dystonia. He's having complex tics, facial dyskinesias, many forms of tics, dystonia, and many forms of functional movement disorders. So we can say now that the diagnosis depends on the presence of a precipitating factor we'll be talking about, the presence of an abrupt onset and spontaneous remission, social stress, paroxysmal symptoms, distractibility, variability, inconsistency, incongruous with the organic movement. Each one has some characteristics like tremors. We mentioned there is a distractibility entrainment, dystonia, there is a fixed posture, and myoclonus, full body jerks, gait, uneconomic postures, and otherwise there is a normal neurological examination, variability between visits. So the patient will present this visit with one symptom and the other visit with another symptom, which we cannot see in neurological disease. Sometimes we can see a baby talk, we can see false weakness, Hoover sign, which is, this is the Hoover sign, While examining a patient, you can find a weakness to one limb. This limb had weakness, but when the patient had been asked by his doctor to raise the other limb, the strength on the affected limb will improve. This is called Hoover sign. We can see delayed exaggeration when testing reflexes. So when you test the reflex, he will wait a little bit and then it will come to be exaggerated. There is extreme emotionality. When the patient came during visits, you just talk to them, ask them any questions, and then crying, tears, a lot. And inconsistency between visits. So it's clear, it sounds logic. So we can diagnose based only on phenomenology, mainly. However, still, we will think about investigation. Yes, I can see that you are suffering from an arrow through your head, but just to play it safe, I'm ordering a bunch of tests. Actually, we usually request some investigation because we have some organic movement disorders which can mimic the functional movement disorder. So we will try to be limited to what we are thinking, and if there is a clear differential diagnosis, we'll go through it. We can paroxysmal dyskinesias, episodic ataxias, acute drug-induced dystonia, dopa-responsive dystonia, Tourette syndrome. All of this organic disease can be manifested like a functional movement disorder somehow. And there is some psychiatric manifestations. There is some psychiatric organic illness like the Huntington disease or the Wilson disease can present with psychiatric manifestations. So it's a little bit disturbing, and sometimes we need to investigate. This is a logarithm, how we will diagnose depending on the clinical history as we mentioned. And we will limit the investigation to what actually needed. Sometimes we need the brain MRI, yeah, sometimes. If we are thinking about Wilson, about Huntington, about such a disease, we will go for brain MRI. EEG, EMG for myoclonus and EMG for tremor will be very helpful. I found it the most important diagnosis here. Sleep study with recording to observe the movements and EEG monitoring to determine if patient is asleep may be helpful in some patients. Sometimes metabolic workup. So what's happening in the brain of patient with an FND? We will get a normal MRI brain. This is normal. We will get a normal MRI brain, which means that the hardware is normal. Hardware is not affected. Here the problem is a problem of a software. So the software can be only seen by functional MRI. We are not using it. It is only used in research. But the functional MRI will be abnormal. And it will show problem with function of specific brain circuits indicating a software problem. So the circuit function disorder is often seen in psychiatric disorder. We talk a lot about this disease, functional, psychogenic, and that it is now neurological. So which means that we have a pathophysiology, we have a cause, which is a very nice because we have now something to say to our patients. We can explain to them what they have. They found that this disorder is multifactorial. There is a neurobiological factors in presence of a predisposing factors and induced by a precipitating factor. So the neurobiology. There is three main important areas in the brain involved in the functional movement disorder. The first one is the amygdala. And the amygdala is the small detector of the emotion in brain. So it will detect the fear, fight, and flight. In patients with functional movement disorder, the amygdala is oversensitive. The amygdala here for this patient is oversensitive, and it has what we call delayed habituation. So it will keep a memory of the event. The memories will be kept in the amygdala. And the second important area is the supplementary motor area. So the supplementary motor area is connected here to the amygdala with an over-connectivity. So you can understand how emotion will be explained into movement now by the connection between the amygdala and the supplementary motor area. The third important area is the prefrontal cortex. And you know that the prefrontal cortex is the area from the frontal lobe, which is responsible for the higher executive function, like the logic thinking and all this important function, which is a little bit inhibited in those patients. Which means that the amygdala will influence the motor output by its connection to the supplementary motor area by responding to sensory stimuli. Impaired right amygdala especially, abnormal connection of amygdala with the supplementary motor area. As a result, the FMD subject do not recognize abnormal movement as under their control. So we can explain now to our patients that you have a problem in your amygdala. The FMD's patient report a lack of voluntary control over their abnormal movement due to the impairment of what we call self-agency. This is the sense of that one is controlling one's action, and it has been localized to the temporoparietal junction, prefrontal cortices, and the cerebellum. In this patient, they have impaired function of these areas, temporoparietal junction, prefrontal cortices, and cerebellum, and they have increased connectivity between the amygdala and the supplementary motor area as we took. So there is increased connectivity between the emotion and the motor area, emotional and the motor areas. Is it clear? I told you it is a multifactorial. We have the pathophysiology depending on the neurobiological factors, and then it needs the presence of a predisposing factor to cause it, to induce it. So we have the predisposing factor. Surely we will start by genetic factors, since we are in the era of genetics and everything is related to genetics. And this actually what we see. Even tics. When we have patients with tics, we know sometimes that the family having tics. When we have a patient, I have a patient a family with a functional non-epileptic seizures. The girl came and I diagnosed her as having non-epileptic seizure. And then the father told me, I had been diagnosed in UK with the same diagnosis. So it is genetics, and it had been proved by many studies that there is a family history which is a proved gene-environment interaction in the pathogenesis of functional neurological disorder. Perfectionist. The perfectionist has many aspects. Perfectionism. So in children who are seeking perfection, and which is different aspect, maybe the parents pressing on their children, they're suspecting a lot, the children themselves. So the perfectionist is related a lot to the psychogenic movement disorder or the perfectionistic personality trait. And the features of perfectionistic personality associated with high academic and extracurricular achievement in 37% of the FMD's patients, especially in girls. So, childhood abuse is another factor, and it is physical trauma, the presence of physical trauma, especially the childhood abuse, for example, and sexual abuse, is too much related to conversion disorder, and it has been proved. And as I found singulo-insular structural alteration associated with psychogenic symptoms, childhood abuse, it had been proved. Coexisting psychiatric illness, and children tend to have predominantly an anxiety disorder and attention deficit disorder, and you notice the tics are increasing even with patient ADHD is very common. Adults have depression more, and antecedent. The precipitating factor, so we talk about predisposing factor. What will induce it directly is the presence of a precipitating factor. I mean, if a child got an injury or a trauma on his leg, then later on, after he recovers, maybe he will have a functional movement disorder in the leg, functional gait, for example. If he's having eye dryness, eye disease, he will have tics of the eyes, which means the precipitating factor will induce. مش عايزين نسمع treatment. خلاص اوكي حاضر حاضر. طيب there is at the end here, after we got all this scheme, we have a sick role or secondary gain. So the patient after having these symptoms, maybe they will play a sick role or they have a secondary gain, but so it will continue. So it will be like a circle, a vicious circle, because the children will play a sick role to have gains from their families. Finally, the management, and it is easy how we will manage, how we will treat the case. The treatment here starts with the neurologist, how to explain the diagnosis. We need to give a good message, destigmatize the symptoms, listen attentively, and explain the FMDs in a scientific manner. Don't ever mention the word psychogenic. It is a functional, and explain it to the family and to the children, identify comorbidity, and it is a team-based approach. So we need two main factors: multidisciplinary approach and family involvement. And the multidisciplinary approach include neurology, psychiatry, physical therapy, and psychology, social worker. Sometimes exercise, neurorehabilitation here is very important, as well as psychologists. So sometimes we will send to psychologists, not always, because some candidates, some patients refuse. I have many patients who doesn't like to go to psychologists, especially the adolescents. So they have to make a mood, cognition, environment triggers. Not all children require, as we mentioned. And as neurorehabilitation, what is main is relearning motor control. It is not a regular physiotherapy, FT or OT. It is a relearning motor control. And visual feedback during motor relearning by mirrors is important. Family members should understand the disease, and school teachers, staff should be involved as well. The prognosis, predictor of good outcome, early recognition and treatment of FMDs, resolution or substitutional improvement in 80 to 90%. So this is good news. And they can resolve most of this patient. A brief duration of symptoms is reported as a good prognostic factor in the majority of studies. And children with tremors, for example, as predominant, tend to have a more favorable prognosis. Age of onset, comorbidity, stressors or precipitant do not seem to affect the prognosis of FMDs in children. So the good prognosis is female gender, mood, well-treated, and accepting the diagnosis, daily spells, somatic symptoms do not interfere with treatments. And finally, my conclusion, that the clinical signs are the most relevant diagnostic tool here. Extensive testing is unnecessary. Treatment starts at diagnosis with correct messaging. Team-based approach is critical for successful outcomes. Comorbidity should be treated effectively. And my take-home note is the only mistake in life is a lesson not learned, and us neurologists will continue always to learn. Thank you so much.
اتفضل دكتور حامد بيه.
Is it good for management?
No, actually they're not giving Prof. هما بيعملوا psychological treatment. Behavioral therapy. They need more behavioral therapy. طبعا except لو كانت exaggerated too much, like we are dealing with tics. نفس الحكايه. Sometimes we are giving risperdal او haloperidol او apiprazole. If it is a very severe and interacting with a life وعامله لهم stigma وعامله كل الحاجات دي. But generally it's only behavioral treatment with relearning of movement.
شكرا يا دكتور هبه.
Thank you, Professor Heba, for your illustrated and interesting lecture.
Thank you so much.
And now Professor Osama Al-Sharqawi will present FDFM disease or ADCY5 related dyskinesia.